Welcome to the show discussing problems and issues of health with Dr. Alcena. For this segment of the show, I'm going to continue to talk about hypertension. When I left off last week, I was talking about the use of beta blocker in the treatment of blood pressure, and I made the point that it ought not to be used as monotherapy, meaning only the beta blocker to treat the blood pressure. And I'm going to continue to talk about that in this segment. Again, I want to bring to your attention worldwide there are 1.5 billion folks who suffer from hypertension. And in this country, you have 76 million folks with hypertension and 67 million with the so-called prehypertension, which may or may not exist at all. And that has to be put in context, as I stated last week, because if somebody has kidney disease and they have hypertension, and you have to handle it in a different way if they have sickle cell disease, and what somebody's blood pressure, which is like 130 over 80, but in the patient with sickle cell disease, because of the propensity to develop kidney diseases because of the sickling phenomena, then you have to really try to maintain their blood pressure between 110 and 70, thereabout. Okay, 110 systolic, 70 diastolic, in that range, because the 130 over 80 is too high for them, much too high. And that would have been placed in the category of prehypertension in some setting. So that's why I said it has to be talked about in context. Somebody is diabetic because of the propensity of diabetes to develop kidney diseases, and the same thing applies. You have to try to keep the blood pressure somewhere around 110 over 70 in that range, as opposed to 130 over 80, 139 over 86 in that range. That would be too high. Now, the death rate from hypertension worldwide is 7.5 million folks per year die as a result of hypertension. And in this country, it is said that some 46 million folks could have been saved if we treat blood pressure properly. You have to understand, of the 76 million folks who are hypertensive in this country, very few of them, only small percentage, are getting their blood pressure controlled properly. Many of them don't go for treatment, and of those who go for treatment, for a variety of reasons, only somewhere between 28, 30, 35% thereof are getting their blood pressure under control. That's a tragedy in itself. And yesterday, the FDA issued a very lengthy report having to do with salt consumption and restaurant food and processed food, etc. This is very, very, very important, because salt is at the basis of essential hypertension. That's the basis for essential hypertension, is salt retention in the body, which is a genetic phenomenon, as I mentioned in previous shows. And the gene that I proposed many, many years ago in the early 90s has indeed been discovered, the G protein receptor kinase type 4, and that gene is found in the same quantity, the same quality in all ethnic groups, because the research was done in black folks from Africa, American Caucasian folks, and Japanese folks. So there is no if or but about it. As far as the human kidney is concerned, we are all African and we are all living in Africa. That's the truth. So therefore, we have to trick the kidney in thinking that we're not indeed in Africa by forcing the kidney to excrete the salt, so that we can then remove the intravascular expansion of fluid, which the salt retention causes, and so doing, lowering the blood pressure. That is no longer an argument. This is not something to be argued anymore. That's been settled. No question about it. That's been settled, period. Now, the thing that's not settled, what's the second or third medication to be used, that's when the problem comes in. Definitely beta blocker, which is what I'm talking about, and the beta blockers are Enderol, Tenormin, Corgad, Timolol, Labetalol, Bistolic, and that range. There are many more out there. These are superb medication. There's no way we could actually practice clinical medicine effectively without making use of beta blocker to one degree or another. But they are not to be used for monotherapy to treat blood pressure. They're just not going to work. You couldn't take a piece of chalk and go to a blackboard and teach me and show me how you could use beta blocker to treat essential hypertension by itself. It's just not going to work. Now, beta blockers can be used to treat blood pressure in the setting that I'm about to list for you. Somebody shows up in an emergency room with very, very high blood pressure, about to bleed into the brain from hemorrhagic stroke. When the systolic is 250, the diastolic is 160. That's hypertensive crisis. Therefore, one can use labetalol intravenously to quickly lower the blood pressure within an hour or so, provided the patient doesn't have a slow pulse. If the pulse is already low for a variety of reasons, either because of the problem having to do with the heart by itself and or other medication the patient is on that can cause the pulse to be low. Keep in mind that all major eye drops that are sold and used across the world have beta blocker in them. That's exactly correct. So if you have somebody who's already on eye drops, you got to be very careful not to add a beta blocker. They're going to develop heart block, and you are in deep trouble. So keep that in mind. When patients are on eye drops, you must be careful how much beta blocker you give them, or if you can give it to them at all, especially the elderly. They already have issues involving the heart rate, and most individuals who have eye problems such as glaucoma, etc., they're older, and you have to keep that in mind. Otherwise, you're going to find a patient show up in the emergency room, the next thing you know, they're into heart block, which is a catastrophe. Why? Because you didn't realize that they're taking eye drops. All eye drops, let me repeat that, all eye drops except the steroids and other stuff the eye doctor will give you have beta blocker in them. And I'm here to tell you, one of the leading individuals who lived in the 20th century who actually is responsible for putting beta blockers and eye drop, etc., happened to be Dr. Percy Julian, who was not a physician, a PhD, who resided right here in Greenberg until he passed away, I believe, at age 73 or 76, thereabout. He's responsible for a whole bunch of stuff. That happened to be one of them. Even people who are in the field don't even know the work that we've done. One time, believe it or not, I asked a colleague of mine who's a rheumatologist, fantastic rheumatologist. He didn't have a clue that steroid was created by Dr. Percy Julian. Can't make this up. I had to refer him to this very long article that was written when he passed away by the New York Times, and I directed him to the New Rochelle City Library, where he could actually get access to this incredibly long, detailed obituary that was written by the New York Times about this incredible man who suffered so much from discrimination, would not be allowed to get a PhD in this country. He had to leave this country as a black American, go to Europe at the University of Edinburgh to do his PhD. You can't make this up because of the color of his skin. He was discriminated against so violently. And yet, look at what he did for the world. I mean, he's done so many things, including the biosynthesis of corticosteroid, and corticosteroids used all over the place. All over the place. You can't practice medicine properly, treat a whole bunch of diseases, hundreds of diseases, if not thousands of diseases, without using corticosteroid. And he did that. And yet he had to skip from this country, run to Europe to get his PhD, and came back and did all that for this country. I just want you to know that blacks have made major, major, major contribution to the field of science as well as to the field of medicine. My youngest daughter told me a couple of days ago, we were chit-chatting, That's some organization that was created, and I won't name it, in 1994. You're trying to take credit for the idea of male circumcision to decrease the incidence of HIV/AIDS and to also decrease the death rate from HIV/AIDS, which is something I came up with and published. You can't make this up. Published in 1986. The AIDS epidemic came to be the way we know it in 1981, June of 1981. I think the first article appeared in the New England Journal, and I published my article from the top of my head that I came up with the idea in August of 1986 in the New York State Journal of Medicine. Now, she told me, I didn't see it myself, but I believe her, that some powerful $1 billion outfit who was doing great work in Africa, which is fine. According to her, there's some place that circumcision is supposed to have been done by the idea, which is ridiculous. And I am a proud Negro, yes, proud one at that, and I came up with that plus dozens of other ideas and so on and so forth. In any event, and this is all published and all copyrighted, and I was advising her, if you have ideas, you have to write it up, make sure you copyright it, and for that matter, even before you show it to anybody, you copyright it, and I show her how to copyright stuff so that people don't take credit for your things. And I told her, I predict the day that God called me home, there's going to be a war in the scientific world for people to try to take credit for the stuff that I've done. I'm alive, and yet they're taking credit for it. Okay, so they're trying to take credit for it, and I'm still here, and I haven't gone anywhere. Thankfully, I have children and grandchildren with doctorate degrees that will be going after these folks if they were to dare try to do that. And some of them can barely wait for me to just disappear so that they can jump up and down and take credit for stuff that I have done, and yet I'm still here. In any event, beta blocker can be used. Let's say, for instance, I just give you one example, the lobatalol. I can also give you another example. There are two conditions. One is there's a tumor, a benign tumor called pheochromocytoma, which can be found in the adrenal gland. That particular tumor, when an individual has it, causes the secretion of what we call catecholamines, which are precursors to adrenaline. These things can cause the blood pressure to go up when you secrete them in large quantity. That, when somebody has hypertension, which is associated with pheochromocytoma, you must use a beta blocker to try to block the outflow of those secretions from those catecholamines in order to control the blood pressure. Yes. Another condition, you have renovascular hypertension, where there's a blockage of the arterial flow to the kidneys. That then can cause an individual to also have the form of hypertension that is not essential hypertension. You have to understand, 97% or 98% of all hypertension are essential hypertension, is essential hypertension. However, those two conditions, pheochromocytoma, renovascular hypertension, those kind of things, you could use a beta blocker to block the outflow of the catecholamine. Yes, you could do that, okay? In addition to that, let's say I'm treating a patient for blood pressure. He or she is on the intense, constant pressure all day long at the job. Now, I will give her regular blood pressure medication with a water pill and a secondary medication if she needs it. But to help her get through the day with all this intense stress that she's on, the blood pressure goes up and down all day long because of the stress, I can give her a small dose of a beta blocker in addition to her regular blood pressure pill to cut down on the intense flow of adrenaline that's secreting. When you're under stress, you're secreting adrenaline. That can cause your pressure to go up, especially when you are suffering from all sorts of stress associated with work-related, race-related, and God knows what else. I can give you a small dose, not as monotherapy, but a very small dose, maybe 10 milligram, 20 milligram, just to take off the edge, as it were, so that during the course of the day, your pressure don't stay high all day long because of the stress that you are experiencing. That's really about it. That's really about it as it relates to blood pressure when it comes to the treatment of beta blocker. Now, if somebody happens to have congestive heart failure or a whole host of other reasons why they're on the beta blocker, sure, you're going to take that into consideration, not necessarily for the blood pressure, for the pulse. If somebody's on the beta blocker because they have CHF, which is congestive heart failure, you have to be careful which secondary medication to give them because some of this medication has as a byproduct or side effect, as it were, of lowering of the pulse. And you don't want to bottom the pulse out and the patient collapse. That doesn't make any good clinical sense. So, again, I'm not going to sit here and detail all this stuff to you. If you were my student in my office or in a ward where I was teaching all, then I would detail all that stuff to you as I'm required to do. Suffice it to say, you have to know these things if it is clinical medicine that you are going to practice. And you have to do it fast and quick. You can't just do this thing by thinking about it yesterday or tomorrow. This is stuff that has to be in the front of your head constantly. It is amazing. You will be amazed. The hundreds of thousands of stuff that practicing physicians throughout the world have to walk around all day long in the top of the head because they have a trillion of a second. They have to do it to save somebody's life or to better the cost of a clinical treatment, etc. Okay, all of us do that. We have to work out all this. You can't work out with this. You see this big book? It's 136 chapters, and I wrote this by myself. Okay, the art and practice of modern clinical medicine. Okay, I wrote this, but you can't walk around the hospital with this book in your hand, nor can you walk around in your office looking at this book all the time. You have to know this stuff already. Every single thing that's in this book, 136 chapters, I can wake me out of my sleep. I can recite them to you because it's all there, because I put it there, okay? 889 pages, okay? And that's what doctors do throughout the world. Some of us write it, some of us don't. Just because they don't write it doesn't mean they don't know it. I'm no smarter than anybody else. I just happen to love writing, and that's my hobby, and I write my stuff down. Okay, now, let me then begin to explain to you how we go about handling someone who presents to us and we just diagnosed with hypertension. Okay? Somebody shows up in the office, and we examine them. Either they knew they were hypertensive, we're seeing them for the first time, or we're just diagnosing them for the first time. Then we have to figure out what has the blood pressure done to the different organs, the so-called end organs. The end organs are the brain, the eyes, the heart, the kidney. These are the end organs, okay? The brain, the eyes, the heart, the kidney. We call these end organs, okay? End organ. Very, very important. So what do? Well, we examine the patient. We naturally will evaluate the patient's eyes to make sure that they don't have glaucoma. That is, the pressure in the eyes are not too high. You have to understand that glaucoma is 5 times more common in black/Negro folks than it is in white folks, right? And I'm proud to use the word Negro because that's who we are. I mean, I was here in the 60s. Believe me, I was here in the 60s when this whole concept of we moving from calling people Negro to calling them black to calling them African American. This is all part of the movement that started out in the 60s. Now, as someone who lived through it, participated in it, all the rest of it, I marched like everybody else marched. Nobody knew there would have been negativity associated with the word blackness. Okay, it was a sense of pride that those of us who were marching in the college campuses, wherever else marching were taking place, we used black to differentiate ourselves from white folks, and so on and so forth. But we didn't even, the intention was not to take blackness and turn it into a negative thing. Well, believe it or not, some folks were happy. Some folks were happy when we refer to ourselves as black. That gave them the impression that blackness is supposed to be inferior to whiteness. You can't make this up. That's what the cynics took it for. They took it and they ran with it. Okay. And another subgroup called themselves African American, meaning they were born here. Okay, they call us African American. Okay, and then some folks took that, they run it with it as well. They try to create division between the Negroes that were not born in this country as opposed to the Negroes that were born in this country. So therefore, they created division. You can't make this up. I'm a writer, and I consider myself a reasonable journalist. I've been doing this, even though I didn't go to the School of Journalism, but heck, I've been doing this since 1992, so I must know something about it, okay? So I'm not making these things up, and I'm an observer, okay? So they took advantage of the fact that, and then all of a sudden, blackness supposed to mean inferiority, and the rest of the world, since America is 321 million folks, with its power, and it's a powerful country, great country, the greatest country on earth as far as I'm concerned, that's the country that has opened its door for me, and I will always be grateful. And I believe it or not, I have traveled out of the country and found myself as one person in the midst of a dozen people drinking coffee or tea or whatever, defending America. And I had to. That's my country, okay? All right? Because and I did it gladly, all right? So, and that was my responsibility, all right? My duty. So, but I want you to understand that as an observer, the intense negativity that's been associated with blackness have prevented, frankly, the worst of the Negroes in the world. You have to understand, there are many more Negroes in the world than there are Caucasian. Many more. Many more. Billions more. But because of the power and money, the Caucasian folks, of which I have nothing against because they've helped me, and my grandfather was one, my great-grandmother was one, have imposed this craziness of superiority on the people, and it has affected health across the world. People have suffered. People are dead and are dying right now because of racial discrimination, from lack of medical care, because of poverty, and so on and so forth. So discriminating against somebody is not just something you do for social reason to make you feel better than somebody else. There are repercussions. The repercussions are poverty, illiteracy, diseases, and death. People actually die because they're poor. They can't afford medical care. So before you discriminate against somebody, your fellow human being, think twice. Think about the consequences of what you're going to do, what that's going to mean to that person, okay? I know. I'm a physician. I practice medicine in Westchester. I don't know of any single doctor, there may well be, because I don't know other people's business, who have suffered more racial discrimination in Westchester than I have, for doing absolutely nothing other than the fact that God gave me a brilliant brain and I'm using it. And for that, 7 days a week, I have to put up with this nonsense and this garbage having to do with somebody thinking they're better than me. It's an everyday thing. It's not like something that happens every second. I'm pretty much practicing medicine from case to case. From case to case. Because they're dying waiting for that case so they can say, we finally got Alcena. He misdiagnosed a case or he mismanaged a case. You can't make this up. And this is true, honest to goodness, at my level. And the folks that are doing it don't know a trillionth time of what I know. And they're in charge. That's right. Because their skins are white, my skin is black, they're in charge. Not because, and they have nothing to do with knowledge. Believe me. Because I know the good doctors. I know the excellent doctors. I know the outstanding doctors. I know them. But those folks who are telling me what to do, who are supervising what, don't have a clue. They wouldn't understand quality care if they needed it to save themselves and save the immediate family member. They wouldn't be able to do it, and then they're in charge, okay? So, getting back to beta blocker then, I got rid of that. Now I'm going to start talking about examining, taking a history from the patient, thorough history from the patient, examining the patient, their weight, their height, their body mass, etc. Take the vital sign, and then you find out this patient has high blood pressure. You have to understand, high blood pressure is categorized 1 through 4. Okay? And then immediately you have to make a decision, number 1, about treatment, but you also have to see whether the pressure already caused damages to the end organs. Okay? So you would do a complete blood count. You will do a complete metabolic profile. You will do urine analysis. You will do an EKG. You will do a chest X-ray. You will order an echocardiogram. Each one of these things have particular reason why you're doing them. Okay, you will check the patient's thyroid profile. You check the patient. You check the patient hemoglobin electrophoresis. That's very important, especially if the patient is a non-Caucasian patient. Okay, you would check that. All right, and there are certain Caucasian folks, you have to do that as well. Okay, and I'm not starting them in name because I don't want anybody getting mad at me, but there are many Caucasian folks from different parts of the world that have severe abnormal hemoglobin. Yes, they have severe abnormal hemoglobin, the thalassemias, etc. So you can do a hemoglobin electrophoresis. Okay, and then you do a vitamin D level, you do a vitamin B12 level. Those are your basic tests that you're going to send off. But you can't wait for the test to come back. Then you got to introduce treatment right away. And one of the first steps of the treatment is the diet. Like the FDA say yesterday in the report, the salt has to be 3.2 grams per day, 2.3 grams per day max, 2.3 grams per day max. Well, the average black folks in this country, NEGRE, I like to call them, eat 7 grams salt per day. 7 grams. Part of it because of junk food, if you want, slash fast food, because many of them are forced because of poverty to feast on this food, not because they like them, but that's what they have access to. Okay, and then when I continue this discussion next week, I'll go into great detail what all these tests mean and so on and so forth. Until such time, keep watching the show. This is Dr. Alcena saying so long and bye-bye.